pronouns and organization would be great. And if you want.
So sort of our first step is we sort of wanted to go through sort of what we're going to be doing today. So we're going to be doing, we're going to have a couple of great presentations. The first, I've got Dr. Jenny Jarrett, who's going to be joining me from our School of Pharmacy to really discuss naloxone, as well as two great presentations from Dr. Pretzel over at U of I, who really runs the ED department in terms of pharmacy there, and has put together a really good workflow, actually as a result of this collaborative last year. And then we have Sarah Elder, who will be talking about their expansion at Cook County and sort of some of the barriers and facilitators that they've had for integrating naloxone as part of their workflow and process in both the outpatient and inpatient settings in ED. So very first step, we wanted to talk about, and if you guys could use the chat option, was as a result of our last session, did you have any conversations with your leadership and team where sort of next steps, where you wanted to go, any questions? So I know this isn't sort of in person, but we wanted to sort of have that same, I guess, ability to really sort of network and mesh a little bit and sort of understand, did the last session inspire your organization to make any changes? Where are you at with that process? Or have the discussions just begun? I'm going to sort of pull up the chat now and see if anyone responds. So any thoughts from anyone? You can also unmute yourselves as well if you want to share.
Good afternoon. I'm Sabrina Wilson from Roseland Community Hospital. I was not on the last session, but we are interested in acquiring the naloxone kits and dispersing them to our patients upon discharge. So that's something that we have been collaborating with different entities to see if we can get those and make those possible at a reasonable cost. It's a cost. So that's something that we definitely want here at the hospital.
Great. Yeah, that is definitely one of the challenges, and we'll be talking about different workflows and cost and sort of how to get around or incorporate that as part. And then we also are going to be having breakout sessions today, where each of the hospitals are going to sort of be separated, and there's going to be one or two leads in the group to then sort of ask questions of experts and be able to work through some of those kinks that you're seeing in your system. How does that sound?
Yes, that's good.
Thank you for joining us, Sabrina, and thank you for sharing. And so I have Dr. Charles, who's an ED physician at Franciscan, and they're in the early process to distribute naloxone as well as initiating Suboxone. So that's definitely really good to hear. It looks like Paul from U of I has used some of the overdose data and trends during ongoing discussions on opioid stewardship efforts, as well as post-surgical opioid prescribing and adding medication disposal bins are some of the things that they've been working on since the last collaborative meeting. Anyone else made any sort of progress or changes or discussion with their leadership? All right. So today, we'll kind of keep going forward. Today, what we're going to do is, again, sort of go through the background information around naloxone, discuss different workflows from both U of I and Cook County, who see sort of a wide range of patients. Then we're going to have breakout sessions, and Andy's going to randomly assign you to rooms. And then from there, you'll be able to sort of do very specific sort of questions and discussions, and really sort of hone in on some of the areas that you want to work on or ask questions about that. And then we'll come back as a whole group and sort of, again, go sort of round robin and sort of see what are your goals for sort of the next collaborative and what can we do to help support you in meeting those goals. And it looks like Samir from Norwegian said that they're dispensing naloxone to all patients that present to their medical stabilization unit and working with the ED on dispensing or giving prescriptions upon discharge. So that's really good. So it seems like there are some hospitals who are in the sort of contemplative, like trying to figure it out, and then ones who are starting that process. So that's really great. All right, so naloxone access, what is the overall goal for this? Well, really any patient who comes in contact with the hospital within the hospital setting, who's at risk for opioid overdose, receives overdose prevention education as well as naloxone. And it's important that there's sort of both of those components. And what do we think about when people who are at risk for opioids? Well, it's of course obvious the ones who are presenting to the hospital because of opioid intoxication or poisoning, also having suspected substance use or non-medical opioid use, or receiving an opioid prescription for pain and some of these additional parameters. So those who are getting greater than 50 milligrams of morphine each day, anyone who's prescribed methadone or buprenorphine through prescriber or program, who've rotated from one opioid to another because of possible incomplete cross tolerance, have poorly controlled sort of respiratory concerns, so like COPD, emphysema, asthma, sleep apnea. Any of these conditions can put them at risk of compromising their respiratory status if they are concurrently using opioids, whether that's pain medicine or illicits. If they have pre-existing renal dysfunction, liver disease, or heart disease, if they have known or suspected excessive alcohol use or dependency, because again, both the opioid as well as alcohol will cause sort of respiratory suppression and can be sedating. And then, of course, concurrent use of benzos or other sedative prescriptions, some ones that are not always thought about but do put people at higher risk, or any of the sleep aids like Zolpidem, that can definitely contribute. And those who have suspected poorly controlled depression who are also on opioids can have increased risk. And then patients who fall into any categories listed above, but may have difficulty accessing emergency medical services. And so this can be another really important area to give patients. And then recent incarceration and release from prison with a history of opioid use, even if they don't have active opioid use, because they're sort of re-entering the environment from a very controlled environment to now a less controlled environment, or where there's more risk factors for them to relapse or use again, it would be really important to offer naloxone to them as well. So what do we know about overdose response and naloxone distribution? So at the very beginning, it was sort of like the thought with any other sort of public health preventative area. If you give out condoms, you're encouraging more sexual activity, which is not true. Same thing with PrEP. So all of these sort of things have been debunked, and the same sort of thought process came out about naloxone. Well, if you give naloxone, that means that people are going to use more, and you're gonna promote drug use, and you're going to promote more risk of overdose. But actually, the evidence shows us the opposite. That there's no increase in drug use, there's actually increase in drug treatment, because patients are looking to you as a clinician or a hospital system as looking at them as a human being and supporting their whole health, right? Including harm reduction as part of that model, right? And respecting their rights. It's cost effective in terms of looking at, I know it costs, in instances up front, but in terms of looking at the big picture and full systems from EMS services, hospitalizations and overdoses that result, and the hospitalizations that result, and the costs associated with that, it's actually very cost effective to use this. There's a reduction in overdose deaths, And it should be centered around people who use drugs. So it's very important.
Nikki, I'm sorry to interrupt, but I don't think your slides are moving forward on our screen.
Okay, thank you for telling me that. Ileana, Andy, would you mind taking over?
Yes, I can share my slides. One moment.
Okay, thank you. Sorry about that, everyone. It's moving on my screen, so I'm not sure why it's not. I'll stop share. Best laid plans, right? Even when you test it in advance, it doesn't always work the way you want to. All right.
Can you see my screen now?
Yes, it's as a PDF though.
Okay.
Your slides have such good information, Nikki. I don't want anybody to miss them.
Yeah, thank you.
I'll work on putting it into full screen, but would you tell me what slide you would like me to be on?
Sure, let's go to slide,
Maybe since people haven't seen them, should you just
yeah,
show
that's
them
a good
all?
idea.
Yeah. I'm sorry, I noticed they weren't moving, but I hadn't seen them before. I should have said something.
Well, it's okay. Thanks everyone for their patience. I really appreciate it. So this was in terms of going through the risk factors was what this slide was talking about. So for those who are at risk, again, we're talking about patients who come in for opioid intoxication poisoning. So this sort of lists all of those points out in terms of the importance of offering naloxone again to any patient who comes in contact with the hospital system in any setting, whether that's inpatient, ED, or outpatient, who have these risk factors should receive overdose prevention education as well as the naloxone itself. Okay, next slide. This is just the evidence for why giving and distributing naloxone and using sort of a harm reduction model of care, how it doesn't increase drug use, it actually increases drug treatment. It's cost effective, it reduces overdose deaths, and really is centered around people who use drugs. And really, this is best practice. So if we're looking at the CDC guidelines in terms of recommendations, they recommend offering naloxone if you have a history of overdose, a history of substance use disorder, again, higher opioid doses, and concurrent benzodiazepine use. And here's some of the Surgeon General's advisory in terms of it's really important to know how to use naloxone and keep it within reach, and it can save a life. And we did some outreach and training here, and we've trained all of our community health workers, and one of our community health workers was just in a Walgreens just picking up some things for her home, and a patient, or I guess a customer there, collapsed. It was determined that she was overdosing, and she actually had naloxone in her purse and was able to utilize it for that patient, and therefore really helped, save a life. So it's important for the public, for general education for public, anyone who's, comfortable using that, as well as the family members around those who use. All right, next. And really prescribing naloxone is often not enough. So there's a really great study that was done at Cook County that showed for 55 unique individuals who received a prescription for naloxone, in the ED, only about 25% took the prescription to the pharmacy, and 18% actually received the medication. And so it shows how important actual dispensing is, because you know that the patient's going to take it with them. And so as we go into our groups later, and Jenny's going to talk about it as well as the other hospitals, first question you want to ask is, are you able to distribute naloxone from the ED? and yes or no. And then based off of that, then it's yes, you start your sort of different elements. And then if it's no, then do you do naloxone prescribing? Is it possible to have an outpatient hospital pharmacy distribute? Or can you refer to a community or outpatient pharmacy naloxone distribution program? Ideally, your highest impact is going to be if you can do ED naloxone distribution. All right, I'm going to pass it over to Dr. Jarrett. Thank you.
Hi, everyone. I'm Jenny Jarrett. It's nice to talk to you all. Nikki asked me to join her in this presentation today to talk a little bit about the different types of formulations of naloxone and what that can have on your impact of dispensing and kind of what is the sustainability and future access for naloxone as you're thinking about building your own systems at your own institutions. So you can see here there's 4 different types of naloxone formulations that are available out there. We have the nasal spray, which is in box A. We have additional nasal spray, which is in box B there, and I'll talk a moment about that in a second. There is a injectable self-injection type of Vizio form there, and there is the injectable vial there in the D box. 2 of these formulations are fairly self-explanatory and have been marketed this way, particularly the Narcan nasal spray in box A and box C. They're very patient-friendly with simple, the way that they look. They're easy to use. The Vizio there in box C actually talks to a layman, and once you pull the top off, it tells you exactly what to do. So that's very helpful for patients. However, those 2 formulations are probably the most expensive formulations, and I'll show you those numbers in just a moment. So while they're very friendly for patients and easy to use, they're not the most cost effective, particularly if we're looking to dispense these medications to people in some format. The naloxone there in B was the traditional formulation of naloxone before they were branded, which is actually just a kit with an atomizer. So the difference with that one is that you have to actually buy that atomizer, which is the nasal converter for that medication, so that you can then spray up the nostrils for patients. If you'll go to the next slide, you can see here that the cost of these medications is widely variable. So the injection is the lowest cost product, and which is what you'll find a lot of times for the free dispensing of naloxone, because you can buy a vial for less than $20, and the pre-filled syringe that you can use with the atomizer attachment is again about $20 to $30, but then you also have to buy that attachment, which is generally not covered by insurance. So it typically makes the nasal spray with the atomizer around $50 to $70 for someone to buy. However, again, like I said a moment ago, those 2 products that are marketed for easy use for the layman or general population, you can see the Narcan nasal spray is roughly about $140. I've seen it lately in the last 3 to 6 months being actually closer to $150. And the Vizio auto injector is really not cost effective in any mechanism, being multiple thousands of dollars for people to pay for out of pocket without any type of insurance coverage. So you can see there's some significant limitations to naloxone pricing. I'm sure many of you who are determining and building your naloxone programs at your institutions are finding that this is probably one of the largest barriers right now, is the cost, and how can we pay for it, and how can we help our patients to receive it, whether they have insurance or not, which is changing drastically in this new environment where many people are losing their jobs and thus losing their insurance as well. And so this is definitely probably the largest barrier we're seeing right now. I'm interested to see later in our breakout groups how people have gotten around this, but this is what it is. So what's the future and what's the sustainability? Because these prices, as they're going up, are not sustainable in any form, particularly as we're seeing substance use disorder and overdoses increase at this point, and thus needing an increase in naloxone in the community. As a small history lesson, naloxone was initially patented in 1961 and approved by the FDA in 1971. And as of the early 2000s, naloxone cost less than or around $1. So you can see there's huge drug cost increases with this medication as we're seeing this growth in need and utilization. So the future, if you'll go to the next slide, is OTC. So we know that there are large pushes, actually in an unprecedented fashion. The FDA has moved to help support the ability of naloxone to go over the counter. So it's accessible in any pharmacy, in any grocery store where you see other over the counter medications such as ibuprofen, Tylenol. Soon naloxone will be available there. And so the FDA, in an unprecedented fashion, went through and actually helped, if you'll go to the next slide, helped the drug companies and actually did their own study through the CONFER study, or the Comprehension of OTC Naloxone. And this was the approval portion for the labeling, which usually takes the longest format of time in order to get a drug approved through an NDA or a new drug application in the FDA. So the FDA went ahead and did the testing for this. You can see the testing drug facts there on the right-hand side. They had two iterations, one that was an injection and one that was a nasal spray. And they tested layman's or the general population's knowledge and understanding of the information of the steps of each form, as well as what naloxone was for, and could someone identify overdose in a patient so that they could use it. So this is something for the future. If you'll go to the next slide. As we move towards OTC, we can see and hope for a lower drug pricing. We know that once things go over the counter, the pricing can definitely drop instead of these large $150 prices that we're seeing for the nasal spray of naloxone right now. We also know that it'll increase the ability for people to access patient-friendly formulations. So a lot of the free distribution of naloxone is in that injection form with syringes, and so that's not always patient-friendly for a family member or a caregiver to give that medication. And we're hoping for increased accessibility. And so reducing the stigma that we have right now with naloxone behind the counter, this OTC product will hopefully build that access. Nikki, I know I'm running out of time.
That's all right. You did great. Thank you. And the one nice thing I think that's important to know is that naloxone's not going to hurt someone, right? So even if you give it, if there's no opioids on board, if you're suspecting an overdose, worst case scenario, it's not going to do anything. And I think that's really important as we educate patients and their family members and the community too. Mm-hmm. All right, next slide. So what are different resources? So the next few slides I'll go through very quickly. They're just examples of where you would be able to get information for prescribers, for patients, for pharmacists, really about the Narcan and the naloxone and the different kits. So you have Prescribe to Prevent is a great resource. Next slide. There's also a whole toolkit here as well that was developed by the American College of Emergency Physicians. And then, of course, Rhode Island also has one as well. So this is sort of an important way that you can sort of have a toolkit, take it, and then sort of, I guess, tweak it to fit your organization. There's also some really great patient videos and handouts, and again, different ones that you can use depending on which one you decide to stock in your emergency department or hospital. And then we have some specific Chicago materials that were developed by the Chicago Department of Public Health, including really nice pamphlets that really give a go-to guide in both English and Spanish, as well as posters that can be put up sort of in your office ER setting, really to know and really help people understand that this is a safe place to get care. And lastly, there are some great billing codes that you can use in terms of education and counseling. So if you do ESPER in the ED or hospital or outpatient setting, these are the different codes that you can use to help support the cost of that education time. All right, I'm going to pass it off to Renee.
Thank you. Can everybody hear me okay? Awesome. So thanks for allowing me to come and talk about the program that we developed at UI Health. Next slide, please. Oop, next slide. I would like to acknowledge Dr. Suki Baines and Dr. Anna Cruz. Neither of them are here today, but they were both instrumental in providing input and helping as we implemented this program and continue it very successfully. So I'm not going to spend a lot of time on all the different barriers and considerations, but I will take a couple of minutes, next slide, to go through what our initial barriers were. It was at least several years ago that Dr. Baines initially engaged me in conversations about, dispensing naloxone to ED patients. And we had a conversation about in our institution being part of the inpatient hospital and not being able to give meds to patients to take home that weren't mandated by law, like with sexual assault survivor medications. And so that initially was one of our big barriers. We engaged in some conversations with Cook County. I had a lot of conversations with the pharmacist in the emergency department there. And as Dr. Gastala previously showed everybody the study they did, talked about what they were doing. And so we initially tried to set it up where we would send a prescription to our outpatient pharmacy and then have them process the prescription and tube it back to the emergency department. But that ended up being kind of a mess and taking hours and hours, and the patients wouldn't necessarily always stay for that long. Our outpatient pharmacy, unfortunately, isn't open 24/7, and a lot of the patients that we see are presenting after kind of normal business hours. And so that also wasn't necessarily very helpful to us. And, as we previously saw, having the patient have to take the prescription to the pharmacy or go to another location, we weren't seeing at Cook County that patients were actually doing that. So how could we get it to them at the bedside? Buy-in initially, we saw a lot of those false narratives, healthcare providers saying, why am I going to give this to the patient? It's just going to make them use more. And so we had to start multiple conversations and education to overcome those. And then cost for us also was an issue. So in thinking through this, we wanted to make sure that we were doing things in a manner that was easiest and most effective for our patients. And as you saw, the different formulations of naloxone and the different prices, that obviously was concerning for us. Next slide, please. So our strengths in going through this process, Dr. Baines was our ED physician champion. And I also will say thanks to Dr. Gastala and Dr. Jarrett, because with different initiatives we've looked into, including this, they've been great resources and very helpful in providing input. We got our safety pharmacist, thinking through how could we get this to the patients at the bedside, and then myself as the ED pharmacist. And then we also have a 24/7 PharmD on call program, which certainly is something to leverage. So that potentially could help us in engaging these patients that we're seeing off hours. Next slide, please. So I have here what our program is. So right now it's the physician in the ED who identifies the patient and then makes me, my resident, or the PharmD on call aware. We then e-prescribe the prescription to one of our outpatient pharmacies. We dispense an outpatient supply of naloxone, which is the FDA labeled package with the 2 intranasal devices. And then we go to the bedside, counsel the patient, provide them an education sheet. If there's any family there, we also will counsel the family. And then we put a note in the patient chart with our education and our counseling and what was dispensed to the patient. We have the patient sign a sheet of paper that they are being given the naloxone, that they received the counseling, and then also that if they have insurance coverage, they're allowing us to bill that. And so then the outside of the box portion of this is that then our outpatient pharmacy is able to process the patient's prescription through their insurance if they have any insurance. And then if they don't have insurance, we're able to use our medication assistance program. Next slide, please. So this is very preliminary data. We actually have some more data, but we're in the process of collecting it, so I didn't put that on here. But this is just a brief snapshot. So we looked at the 3 years prior to implementing our naloxone bedside program. And you can see there were very few naloxone prescriptions that, you know, there was a decent proportion of these patients that were uninsured, and none of them got naloxone in hand or pharmacist counseling. And I'm happy to report that of the patients that got that got consulted for naloxone in the ED after this was implemented, that we were able to give naloxone in hand to a fair number of them and get them that counseling at the bedside. Next slide. So we're continuing to assess the impact of this program. We want to increase our provider education so that we're capturing all of these patients. EPIC is coming to our institution in a couple weeks, and we're hoping that will help prompt the physician through some of the order sets to actually trigger the naloxone consult. And then we would love to expand this to other regions of the hospital besides the emergency department. And I think that's it.
Thanks, Renee. That was really, really helpful. So hopefully that gave some food for thought for the discussion and breakout groups as to how you can sort of, what's one example of one model that can be used in a very, I think, sustainable way in order to be able to dispense naloxone to patients. Next up, we have Sarah Elder from Cook County. So again, thank you again, Renee. That was really great. Sarah, you ready?
Yeah, Sarah's running a little behind. She was wrapping up another WebEx call. She should be joining within the next couple of minutes. I think she just texted me that she's joining. So sorry for the wait. Bear with us. Thank you.
While we're waiting, does anyone have any questions for Renee? You can put it in the chat box or unmute. So Renee, I was wondering, based off of like your perspective, once, how did you guys go about educating the nursing staff and emergency docs and clinicians to start doing this? Like, was that process, how was that sort of process worked out for you?
It was like all of my education in the ED, which is multimodal and repeated reminders. Sometimes I feel like I'm annoying them, but we did in-services for the nurses. We did an education session for the physicians. And then email kind of blast to say, hey, don't forget about this. And especially recently with the new interns that we're starting in the emergency department, again, just kind of making the interns aware that we have this program, and then just a reminder for everybody else. I think once we started to do this, the nurses saw the benefit that like the patients were getting this and able to go home with it. And so that was like positive reinforcement. And sometimes it was the nurse prompting the physician like, hey, this is a patient who could get naloxone. So that was really great to see. And then the same thing, our pharmacy residents are integral because they're on call, and they really enjoy this this program and feel empowered that they're helping these patients by being able to do this at the bedside. So it's really been great. And yeah, just lots and lots of education.
Yeah, absolutely. All right. So I think that's always the hard thing about initiating any sort of new procedures or workflow, especially and depending on how big your hospital system is. And again, doing that sort of multiple modality of education. But I think it goes to show that all you really need is a great pharmacist lead and and one or two ED docs on board and your administrative support. And I think that would be, that's really sort of what you need, just like any other big project in the hospital. And then once you see how such a, positive impact it can have on the patients, then it becomes sort of self-sustaining after that. So
and we were in a little bit of a bind because we currently have Cerner, and Cerner's going away and we're getting Epic. And so we also were going to try and do some prompts within the medical record for these patients and the providers taking care of them. But unfortunately, we weren't able to do it this past year because they kind of put a hold on anything related to Cerner. But I think like utilizing whatever system you have, if you have a way to do that when these patients come in, we're excited that we may be able to do that in the near future with Epic too. So
yeah, that's awesome. Oh, great. Thank you, Renee.
mm-hmm.
Thanks again for all your hard work for this. I know it was a big project, but definitely worthwhile. So Sarah has joined us. Sarah, can you hear us okay?
Hi, yeah, how are you?
Good. All right, so we're going to get your slides set up for you. All right, thanks, Sarah. Go ahead.
Great, thank you. So thanks everyone, sorry I'm late. My name is Sarah, I'm the manager of behavioral health at Cook County Health. Specifically, my role here at the health system is to support our recovery coaches in the emergency room, a little bit on the inpatient side, but then also in our 14 ambulatory care, primary care community sites throughout the county of Cook. Cook County Health is not completely at the point of dispensing yet, but we do have some co-prescribing efforts that have been underway for quite a long time, and some specific updates that we would like to share today. So in our ambulatory care health centers, or ACHN as we refer to them here, we offer medication for the treatment of opiate use disorder plus recovery coach support at 14 of our sites across the county of Cook. In our settings, our recovery coaches are paired with a provider and a LCSW that all work to support patients who are coming in and meeting with the team either weekly, bi-weekly, or monthly, kind of depending on where they're at in their recovery. we have a couple of tools to move along our co-dispensing efforts. Our co-prescribing efforts. We tried to make essentially the right thing, the easy thing to do for both our providers and our patients. So in some of our forms and our tools that both of our providers and our recovery coaches use when they're documenting, we created a couple of things just to kind of always remind and make that really easy for folks. So one of the first things we did is we built a order set or a care set for anyone who had a diagnosis code of opiate use disorder or an affiliated diagnosis, that there would be an automatic care set to remind the provider to prescribe naloxone. Additionally, the note templates that our providers who are prescribing buprenorphine prompt them at every visit to co-prescribe naloxone. And then at every visit with our recovery coach as well, there is documentation that prompts the recovery coach to ask if the patient has been trained on naloxone. If the patient doesn't have the training, they can provide that training directly. Otherwise, the recovery coach asks if they have a naloxone kit at home or if they need one today. And if a recovery coach documents that yes, the patient does need one today, that pulls into the flow sheet for the provider, again, to prompt the provider to co-prescribe. At Cook County Health, we also have a safe opioid prescribing task force. So I think, probably everyone or most of the folks here at this meeting today know that locally our overdoses are largely related to illicit opiate use. However, we do want to make sure that we're addressing the prescription of opioids. So our Safe Opioid Prescribing Task Force that started in 2015 has automated alerts in the electronic medical record to co-prescribe naloxone for any prescription over 500 MMEs. So we currently are working to have an automatic dispensing for folks with over 500 MMEs, and again with folks who are receiving buprenorphine or naltrexone with us, but currently we're stuck with some pharmacy software challenges to support some of those dispensing efforts. For our co-prescribing efforts, some of the other things that have helped move this along on both the inpatient and the emergency room side is that if a patient is on our inpatient floors and the medical team orders a consult order for the expert team, there's a checklist that pops up in the medical record that includes a prompt for the medical team to prescribe naloxone for that patient. Again, that order set or care set for folks with opiate use disorders is system-wide. So it's our ACHN, but it's also our inpatient and ED as well that are getting this. In our emergency room, we have recovery coaches that encourage providers for every patient that they encounter with opiate use disorder. Once a recovery coach has gone in and kind of identified what the patient needs, what the patient wants, whether they want treatment, we want to refer to treatment services. Even if, if a patient says, no, I'm not interested in services right now, the recovery coach always reminds that provider when they see a patient to please prescribe naloxone at discharge. And in our electronic medical record, we put the CDPH naloxone brochure into our patient education, so that can be printed off with all the discharge papers that a patient gets upon leaving our facilities. We also, our providers can now e-prescribe, which I know is I think from the providers that I've worked with is kind of an antiquated thing, but Cook County Health can now e-prescribe, so hooray. So next slide here. For our dispensing efforts, like I said, we're not there yet, but we are getting closer. We do now, I think since last year's go around, we have increased buy-in from some of our senior leadership. Some of the things that have helped push the needle for our executive leadership team has been some of the local data, specifically around opioid, the rise in opioid overdoses here. And we've had some personal experiences on our leadership team about people that they have loved have experienced an opiate use disorder or an overdose, and I think that has unfortunately helped move the needle as well. We now have funding from extramural resources. This was a large concern about dispensing from our leadership as well, is having the funding to support it. We have the training tools prepared and ready to go. All of our recovery coaches have gone through Train the Trainer training and gotten certificates, but unfortunately we are faced with a couple of challenges and hurdles still to overcome. So the biggest one I think is that we really had a lot of momentum and we're really moving on this, and then COVID hit. So understandably, I think, probably with everyone else in the room, we had to pivot on a lot of our priorities. So, and unfortunately, this was one that got deprioritized. We also, amongst COVID, we had a bunch of leadership changes, both at our executive level, at our emergency room level, kind of throughout the system. We had some leadership changes, and so are working on getting folks kind of familiar with where we were at in the process and hoping to help keep moving that forward. One of the biggest hurdles that I think we are working on right now is that Cook County Health has a policy not to dispense any medication. And so there definitely is a consensus amongst, various levels in the organization that there should be an exception made for naloxone, particularly given the rise in overdoses. Right now, we just have to make sure that we have to update that policy so that it's consistent with practice, just to ensure coverage for any Joint Commission visits and stuff like that. So for our ambulatory care, primary care health community centers, we are also getting closer to getting to the point of dispensing. We actually had efforts to pilot dispensing at one of our clinics that it is currently providing medications for opiate use disorder and recovery support. We had the site leadership engaged and supportive. Again, we did the Train the Trainer with the recovery coach. We had all the materials. We are going to keep it in par stock with an order for a nurse to dispense. So that would be our workflow. But again, we're still stuck with that system-wide policy that we're working on updating right now. Some of the additional challenges that we're currently up against is just developing a tracking process to make sure that we understand and are able to report out on all the naloxone kits that we do dispense. And then we do believe that one of our limitations, even once all of the internal tape is crossed, that we will be limited to only dispensing to registered patients. So we unfortunately would be limited to, if they're a family member, caregiver, etc., we could only dispense to that patient who was registered at Cook County Health. So, so certainly not, not more of a kind of operational, logistical, I think, an annoying hurdle, but definitely not insurmountable. And lastly, in our emergency room, I think we've reported to this group before that some of the challenges we have is that, we are definitely increasing our numbers of providers who are able to do few initiations, and so that comes along with a care set to prescribe, and hopefully we'll just to prescribe naloxone. What we unfortunately have seen is that less than 25% of our patients actually walk. If you've ever been to Cook County Health, there's just one really long hallway from the emergency room to the pharmacy. It's a straight shot, but unfortunately, 75% of our patients don't stop and pick it up before they leave. COVID obviously is a challenge in our emergency room. It just has deprioritized a lot of initiatives that we had momentum around. Some of these challenges I already talked about, but so one of the things we did have before is our recovery coaches. If a patient does accept treatment services, we offer transportation from our doors to that treatment provider. And so a lot of times our recovery coaches are waiting for that transportation with the patient, and we're able to kind of encourage stopping at the pharmacy to pick that up. So again, not at dispensing yet, but making some strides. And that's it. Any questions?
All right. Thank you so much, Sarah. That was really helpful. So our next component of this is really the breakout sessions. And this is sort of to provide a smaller group, sort of, again, to try to make this more personal, to provide sort of technical assistance, work through some of these, concerns and challenges you may be having, or to help you sort of develop where your next goals are. So we're going to be discussing things to think about. Where's your hospital currently at regarding naloxone distribution? Are there any barriers and facilitators? How can you leverage these supports? And how can you approach solutions to these identified barriers? Also, what are the mechanisms within your health system to improve the cost of naloxone for your system or your patients? So think about sort of what Jenny brought up about product, place of dispensing, and insurance utilization, kind of what Renee was speaking about. And then what are your education goals for patients and families and healthcare staff to support access of naloxone? So working through that stigma as well from the clinician side and from the support staff side, identifying clinical champions and how to sort of integrate that education for your staff. And then also what patient information are you going to use to be able to really to roll this out. So I'm going to leave this over to Andy. She's going to randomly separate us all. So we have about 20 minutes and you'll be automatically brought back in for a recap. Sort of that outpatient pharmacy component to be.
Yes, we do not have an outpatient pharmacy currently. We are exploring that idea whether we will go into having our own outpatient pharmacy to help with not just that medication, but other issues that occur with our patient population that we service. We used to have an independent closed down. The Walgreens was not too far from, so things were being met, but that Walgreens, due to the I'm going to call it the rioting and looting, my nearest Walgreens is shut down.
Yeah.
Anything else I
No,
can
that's
add?
all.
Or?
Thank you. Anyone else from the other groups? We only have about 5 minutes left, but I just wanted to give anyone a chance. That if there was some sort of goals they had or areas that they wanted to bring up that they wanted to work on, that they wanted assistance with.
Hi, Les. Oh, that's Nicole. This is Sabrina. Thanks for everything, guys. I'm sorry I missed last month, but I will be back on the 19th. And I'm going to try to find out how my outpatient pharmacy and the insurance works as far as the distribution. Hopefully I can get that answer by the next month.
Great, thank you. Anyone else have any sort of goals or next steps?
This is Suki from the last from our group. Paul, you had mentioned something called Narcan Direct, and there was a question about large scale purchasing and like sort of trying to figure that out. I was hoping you could speak to that to sort of help at a larger scale of the cost situation of trying to get access to naloxone was a barrier that came up.
Yeah, briefly, we were mentioning it seems like it's a very common struggle is how are we going to pay for this? And we mentioned a lot about for long-term sustainability, trying to find a model where it's being run through prescriptions for patients is probably more sustainable. But if we're having to use grant funds or other hospital support or that, if you can't use obviously the more affordable options that are available as far as the injections or the nasal atomizers, and you do want to go with the Narcan nasal spray instead of there's a program called Narcan Direct, which does save a little bit of money versus going through a pharmacy wholesaler. You directly purchase from a wholesaler, and it does save some money, although it is still more costly than the naloxone intramuscular injection or other options out there. So we just wanted to make it aware if you weren't that Narcan Direct is a program that's out there.
That's great. Thank you. Any sort of little bit, I think, helps, especially when you're talking to your hospital administration, then doing sort of financial planning during this time, because I know COVID has really, hit hospitals pretty hard, pretty much everywhere, right? So that can be, a big concern, of course. Any other thoughts or ideas? Any other questions that anyone wanted to ask? All right. So what we will do sort of next, next slide. So the next component will be the evaluations. It'll pop up on your screen shortly. This is really to give us feedback so that we can sort of continue to plan and do these presentations. Again, we moved from in-person to virtual, so any sort of feedback that you can give us would be, really helpful. So thank you for doing that. And your CME and CEUs that we've provided are attached to this. So if you could just take a few moments to do that real quick, really appreciate it. And then the certificates for CEUs and CMEs will be emailed later. And if you have any additional feedback, Andy provided her email address in the chat box, so you can reach her. And then we will also be sending out the slides and recording. And if there's any sort of additional information you want, whether it's workflows or protocols that you would like to, or patient material that you would like, just let us know. And then you're happy to have it, and then you can sort of take it and adapt it to your own sort of healthcare system. Also, please reach out if you want any technical assistance that's free as part of this program. Really, if there's any specific interests or goals that you think you need some additional help with outside of the learning collaborative in this sort of setting, if you want sort of like tailored technical assistance for any parts, whether it's naloxone or Suboxone, just let us know. All right, next slide. And again, thank you to Ileana and Andy. These are their email addresses if you have any questions or concerns throughout this. Next slide. And then, so I think that's about it. The next session, Eliana, do you want to talk about the next session date and time and topic?
Yes. So the next session is going to be on medications for opioid use disorder, specifically focused on buprenorphine, and talking through some workflows and things like that. And the date for that is going to be on Friday, September, sorry, I had the wrong date pulled up. Friday, September 18th, same time, 12:30 to 2. And we'll be sure to send out some reminders and whatnot in advance via email. So looking forward to seeing you all there for that session.
And thank you, everyone. Thank you for your participation. Thank you to all of our speakers. Really appreciate your insight and guidance. You guys have already done a lot of the hard work. And so sharing the barriers and facilitators, I think is just really helpful as we all sort of navigate this process. So thank you all for doing that. All right. Thanks, everyone. Have a great day and a great weekend.
Have a good weekend.